start our session at 7:56.
No problem.
Thank you so much, sir. Requesting all the participants, those who have joined, to just tell your friends
Join.
just inform them that to join in time, so that like it's already 7 and we only have one session. So it would be nice if all of them can join before 7:10. Sir, I made you the co-host, sir. You can share your slides from your side. If there is any problem, I'll be there as a backup.
Right.
I think I see Shraddha from Echo India, Shraddha Sharma. So I just wanted to know if Shweta is going to join.
Hi, actually I'm here to observe the session.
Okay. So I just made you the co-host. So just in case, like I request until Shweta joins, I request you to just help us being the backup.
Sure.
Thank you very much. Yeah, good evening, one and all. I think it's close to 7:05 and we need to start a session. So before we actually go into our session, once again, good evening, good evening, everyone. This is Vinila, Program Coordinator from Hyderabad Center for Palliative Care. So I request all the participants to kindly mute your microphones and turn on your video cameras. This is very, very important for us. I see most of them have renamed yourself. So you are now very familiar with Zoom application. This is important to mark your attendance. And if you have any questions during the session, I request you all to please unmute and speak, and keep your microphones muted throughout the session and video cameras on throughout the session. If you have any questions, please, you can always raise your hand and ask the question, or also type it in the chat box. So, and over to you, Suren sir. I would like to just give you, I think most of you know Dr. Suren. So, Dr. R. Suren Thirakumaran, sir has done his MD in Community Medicine. So, sir is a consultant community physician and a senior lecturer in Department of Community and Family Medicine. His sir is a faculty of medicine in University of Jaffna, where you all are undergoing training, 6 months of training program under sir's guidance. So, sir has shared, as sir is also a chairman for Cancer Aid North and East in Sri Lanka. And such a great pleasure, and like we all feel very honored to have you here with us, sir. And over to you, Suren sir.
Thank you, Vinila, for your kind introduction. It is good that after the 6-month course, and I'm able to come and meet you all and have a kind of a discussion, particularly developing the palliative care services in northern Sri Lanka. But this is applicable even for all Sri Lanka. But then there are participants coming from other part of the country also. So I'm going to share some experience, not particularly the Indian model of, because all over the world there are different models used to develop palliative care. And you were learning all the how to manage the symptoms and the emergency in palliative care, terminal ill, and ethics and different aspects of the palliative care. Today our lecture, this 1-hour lecture, and maybe I want to have a kind of a discussion with you, not as like a lecture. This is about the palliative care development. So we have to see present care services, need for the care, things made, a need for expansion, way forward, and these are the things that I am going to discuss with you. So you all discuss, no? Then death is imminent. Most of the time we don't accept the death, so we don't prepare enough. But it's very important that make all of us to prepare for the death. So particularly that you learn about the palliative care definition. The palliative care definition is telling, so anybody with life-threatening disease should be provided or be able to cover the palliative care. So in that aspect, so this diagram is very familiar to you. So usually public health people that are involved, my field is prevention, but the prevention is at all levels. So prevention here, so after developing illness, usually we start this curative and prolonging care. So life prolonging care, some of the instances that we just only start this life prolonging, some of the instances that we try to develop this curative, right? So then simple example, when we get an newly detected diabetic patient, very in the early stage, or maybe the young diabetic patient, when they come to the clinic, so most of them, they come to either medical clinic or maybe in the primary care, that outpatient department clinic. Then most of the time we try to sort it out their blood glucose control, and also then look at other risk factors. Now we do them assessing their BMI, cholesterol, and then the blood pressure and all those other risk factors. So we try to control the disease and not progressing. So then that's the way then we can prolong the development of the complications. So that is our main objective when we are getting the patients at early stage. But then after a few months to few years, these patients come to clinic and they make complaint. They say, I have that night, I get pain. Then maybe they get the peripheral neuropathy. Or maybe then after walking certain distance, I get leg pain. Or maybe then after walking some distance, or maybe doing some work, I get some shortness of breath. Or then maybe then my night urine frequency has increased and it's affecting my sleep. Or maybe then I don't have any kind of appetite, or maybe the constipation. So these kind of complaint that people make. So when these people are making complaint, so we try to manage the symptom. So then we move to the thing. We were doing only the disease control. Then we move to the thing is called symptom management. So we moving. So that's where that we all this palliative care. So we try to improve their quality of life, and then make them to have a kind of a meaningful life. So if the person can't have a sleep in the night, so they can have a meaningful life. The following day, the daytime, they can concentrate their work, and it's very difficult. So if they are constipating for more than several days, and that can affect their day-to-day activities. So in this progress, we should be able to provide some sort of care. So we will get majority of the patients, then they will move to this thing, and then we will get the patients their life closure. So they are going to die in a few months or maybe 1 year. So then we know that people are going to die. So in life care, dying patients. Then after death also, we should be able to provide the care. So now you know the spectrum of care we should be able to provide, and also we will get the patients in different level. So our healthcare care system or palliative care system should be able to cater or that able to provide and then cover the care, whatever this stage when our patients are. So this is the status now that we need to think how we can develop the care. So at what levels? So what are the possible levels the care could be developed, right? So any suggestions? Now based on this need, at what levels the care could be provided? Anybody has any idea? Biduran?
So Dr. Shobika sent some direct message saying that all levels.
I couldn't see.
Yeah, it came as a direct
comments.
message, sir. Yeah, it came as a direct message, personally.
Direct to you.
Yeah.
No, that all levels. That's what Shobika that. Yeah. What do you mean that all level? When we are talking all level.
Dr. Shobika, can you just please elaborate if you don't mind? Like Dr. Suren is trying to ask you when you say all levels, like just please elaborate on
Shobika,
that.
then can you?
Please request you to kindly turn on your. Yeah, again she sent a private message saying that proper education should be given in preventive section.
I'm sorry.
Dr. Shobika sent saying that
No,
proper
that
education.
actually care.
Yeah.
That we should able to provide at the institutional level, and then the institutions mean we have to see this in the healthcare institutions. So healthcare institutions in Sri Lanka, we know then most of the patients, they come to this kind of chronic patient, they come to outpatient department. Then in the institution, there are two departments. We have outpatient department and then the inpatient department. The outpatient department, most of the patients, they come to either medical clinic, or maybe in the diabetic clinic, or cardiology clinic, or maybe nephrology clinic, or neurology clinic. So then everywhere then will and they will go for a different and the different symptoms. I will come back to these slides. You learn now to whom that we need the palliative care. Have you seen this before? Any lecturer share with you? Dr. Good.
No, sir.
So to whom that the mostly needed group, who are the people? Most of the time, we think that it's for the cancer, but it's not the case in the world. That is applicable for Sri Lanka. So which group is mostly needed? The cardiovascular group. Then only cancer. Then we have a chronic lung disease, HIV/AIDS, diabetes, then liver disease, kidney disease. Right? So particularly then in the north central, there are a lot of patients with these CKD unknown etiology. So they need palliative care. So the requirement of palliative care muscular dystrophy, or some of the muscular, or some of the genetical disorders, or maybe with a cerebral palsy, simple thing. So then they also need palliative care. So then our care system should able to cater or able to provide, and then people should access the need of palliative care. But unfortunately, we are not able to provide that. Majority of our patients are not able to get the palliative care. So in Sri Lanka, the palliative care is a very new concept. So we started to discuss most of this palliative care concept after 2010. And then our Palliative Care Association of Sri Lanka formed in 2014. And then our National Task Force of Palliative Care by the Ministry of Health was formed also in 2013. And then the SLMA Task Force for Palliative Care, Sri Lanka Medical Association. So all these things are started in this in 2010, not before. And also now that we have a palliative care policy strategic document launched by the National Cancer Control Program, because National Cancer Control Program Sri Lanka is the focal point of palliative care in Sri Lanka. So they actually published this just before the pandemic. So 2019 November only they have officially launched the strategic document for the palliative care. So I will discuss with you what the document is saying, that what sort of care that we have to develop, right? So the palliative care, it should be appropriate and should be available for all patients from the time of diagnosis with a life-threatening or debilitating condition. You know, then these patients, not only for the terminal ill patients, right? Not only for the end of life patients. So it should be available for all the patients, those who are, right, from the time of diagnosis, right? So time of diagnosis with life-threatening or debilitating condition. So already we have discussed that life-threatening and debilitating condition. And then we can have a different models of palliative care. The world is having different models. North America has different model. Europe has different model. Indian subcontinent, India, they have a different model. But the model should ensure maximal benefit. So its services should be integrated into all healthcare settings. So we can't develop a separate or parallel, some kind of a vertical program. Vertical means that having a more palliative care medical officer in palliative care, all the districts, and ask them to run the palliative care services. It won't work. So like what we are running, some of the people involving in public health, they know anti-malaria. Or some of the things that we have STD AIDS. So it's not possible for the palliative because palliative care patients are everywhere. Palliative care patients are treated by general physicians, cardiologists, nephrologists, neurologists, so endocrinologists. So they are everywhere. So our system should be able to capture. And also these people all should learn about palliative care. But unfortunately, our medical curriculum, now only then 2 weeks back, then National Cancer Control Program invited all the medical faculty, deans and representatives to discuss, to include these things in the undergraduate curriculum. And also our postgraduate Institute of Medicine, they started diploma course. Now they are starting the MD in palliative care. So slowly that the palliative care is becoming kind of a accepted care model, so into our healthcare system, right? So usually the most of the time that we think that we have to have a palliative care specialist and then palliative care team, right? So then most of the developed countries, that is a model. So they train many palliative care specialists and then also get these hospices. So you study now how this hospice movement, right, started in Europe or this UK and then move around the world, right? The hospice is a place to provide the care. So, but for a country like us or developing world, we can't only depend on the palliative care specialists because we can't produce enough specialists. So to producing specialists, that is particularly that here in Sri Lanka, even postgraduate course, other postgraduate courses are fee-levied course, but that here the medical postgraduate courses all are free. So then when you want to train one graduate, that we have to spend at least 20 million Sri Lankan rupees to train a specialist. So that for our small budget, this was so difficult. So we can't think about to get this palliative care specialist alone to run the things. So we have to have a different levels of care providing people. So one of the things thing I was telling, when we have a different one is institutional. Second thing is community. So we need to have a community based particular nursing home, hospices, rehabilitation centers. Any idea? Sorry, I lost my connection. So any suggestion? Any idea of Dr. Kandiban? That care home, nursing home, hospices, rehabilitation centers. Any suggestions?
Sir, as usual, this group is a very quiet group.
Not as usual, it's a Sri Lankan style, not like no. So, Dr. Jayaraja, any idea and suggestions?
Due to the poor connection, I didn't get you. Can you repeat again?
Yeah. No. What I'm asking, there are different levels of care providing centers, particularly for elderly people. One is elderly care homes, nursing homes, and then the hospices, then the rehabilitation centers. So how we can differentiate these centers?
So basically, basically the differentiations we can differentiate as two. Some places there are no any basic medical facilities.
Hmm.
They are keeping the elderly people without any medical facilities. Actually, the elders home, the elders home and all in our settings, all the elders home and all, most of the places they don't have simple diagnostic methods or some responsible person to give medications or follow up to the elderly. I think in those are the elders home. I think spices I don't have experience that much. But in that places I think they can put good care.
Yeah, actually nursing homes, as you correctly said, Dr. Jayaraja, the elderly care home, sometimes that people have a daycare home or maybe elders home. So nowadays in Sri Lanka, that is becoming very popular, elders home. So there may be some other staff to support to their day-to-day activity, cooking and things. So sometimes they get some healthcare assistance to support, assist them. So that kind of care. So then nursing home. The nursing home actually is a nursing. So then nurse-led homes. So there must be some other way trained nurses. Then maybe then train in kind of a private sector. There are now different training institutions. So they can train, or maybe then state sector nurses. So the nursing homes. So now only that slowly that nursing homes are coming up in Sri Lanka. And then hospices, still we don't have a proper hospice. So I can share this the particular hospice what I am at the moment our chairman of that charity. So that is in Inuville. So this is not functioning as a full hospice. So what hospice available in Hyderabad or Calicut or Trivandrum? So here that we don't have. But recently very good hospice is developing Karapatia. Karapatia Hospital. There's a very active surgeon. He developed a model hospice within the hospital premise. So it's supported by DFCC Bank and then build a nice luxury one. So it's a good place for you all to visit. So similar kind of hospice models are important. Particularly the hospices are needed. So I can share the video later. That video can, excuse me, 1 minute.
Requesting all the participants to please kindly
Hello?
turn on your video cameras. So, Ms. Verni Bala, Dr.
So
Shobik.
the,
Yeah, yes, sir. Carry on.
yeah, the hospice is actually there are three purposes. The mainly three purposes. So what are the three purposes? Right? Hospice care. One thing is when we diagnose, when we have a, what happened to my things? Okay. When we diagnose, or maybe the patient, when we see that we feel this patient needs some care, but at the moment, this kind of patients, we are treating them in the hospital as an inward patients, right? So very good example, some of these cancer patients, they finish their treatment. So there's no, they are not on this chemotherapy or radiotherapy or hormonal therapy or any other therapy, but the patient has a pain, uncontrollable pain, or maybe having kind of a difficulty of breathing, needs some oxygen supply. So then they need some kind of a ascites, or maybe they need tapping. So some of these kind of thing, we get them to the hospital, normal hospital, and also admit them to the ward, hospital ward. So what happened? These are palliative patients. So they need more comfort care, the kind and comfort care. And also we get patients with the acute diseases. So they are not in the level of palliation. They are actually people with this accident, acute MI, or acute stroke, or then these kind of patients also, they come to hospital. So these two patients are filling up our ward. So when we are providing care also, we struggle. So our team, the medical team or healthcare team, really struggle to manage these acute and all these patients, and also patients with the palliative need. So the hospices is a good place where even family members also can come. The hospice would provide the thing. They have to have a kind of a very healthy and then comfortable environment where they have to get a care one-to-one actually. So if it's a good hospice, you should have a room with the bed, attached bathroom, and all these facilities. Family members can come, one or two people come and stay, and particularly then discuss their issues and symptoms, So they have to have a kind of feeling. But while they are here, they need some medical treatment. So there must be a medical team at the hospice. We can't run the hospice without a medical team. So there must be a medical team that is trained to provide 24 hours available and all the other facilities also. No oxygen supply, infusion thing, right? IV, that that's injectables. So then tapping, all these kind of things should have minor procedures. So all these things should be able to done in this kind of a setting. So that is hospice. So hospice, these kind of patients for the symptom management, we admit to hospice. So one of the thing. So for the temporary symptom management, and then after temporary management is over, they can send back to home. And from the home, then they will come back to something that if the pain, or maybe come to the hospital clinic. In the clinic, when they feel right, this patient needs thing, then we can send these patients to the hospice. So then hospice should be able to provide care for this kind of patients. And also hospice provide another care that for the patients with the end of life. So most of the time what happens in our end of life patients, they come to the hospital again, come to the emergency. Most of the time that their relatives take these patients to the emergency. The emergency care patients also come there. Palliative patients also come there. Then they compete. Then after the thing, again, then after 2 or 3 days, then people discharge. The patient, they discharge and ask them to take it to the home. Then after taking to the home, and again the patient maybe some feeling of again difficulty of breathing, or maybe the not able to take any food and things, or kind of agitated, or maybe fitting. So all these things, then the people they bring back these patients to the hospital. So this kind of a thing for the family members, and also to the patient, and also healthcare providers. So then most of the time the people tell in Sri Lanka, then hospital said they can't do anything for this patient. Then the hospital said we can't do anything, please take this patient to our home. Then but after taking to the home, they can keep that patient there, and they will bring back to the hospital. Again, hospital people say, no, we can't do anything. Right, we have acute patients and beds are full. Please take this patient back to home. So this kind of patients, we should be able to have a hospice. So they can come there, and until the patient settle, and also then with the support, and they can have a kind of a symptom release, and also somebody can touch and then console the patients, and having kind of talking in a kind words and things, so make them. So you all know, then when we were small, then when we get any disease, mother, no, then most of them are mother or grandmother, or somebody then come and say, no, right, you will recover very soon, don't worry, that kind of things. No, that these are the things very important when we are providing the care. So those kind of things should be able to provide in the hospice. The third thing is the hospice should be able to provide, we call respite care, RESPIT, respite care. Respite care means even when we have a patient with a bedridden for a long period, so maybe for 6 months, 7 months at home. So more than the patient, the care provider will get problem. Right? They get physical problem, mental problem. They can go to some other functions, or even they can go to some shopping, because they must be there always to provide the care. So they allow it. Then they will also get kind of a frustration and think. So that kind of people, so for their thing, they can bring these patients for a week or maybe 2. So then maximum maybe a month, 1 month, they can bring the patient and keep them in the hospice. So then they can relieve and they can do some mental, physical activities to relax them. Then they can again get ready to provide the care of the patient. So these are the 3 aspects the hospice can provide. But very important, when we want to provide the palliative care, these 2, institutional palliative care, hospice-based palliative care, should be integrated by the community-based palliative care. So particularly at home. So most of the time the patients, so our patients also, they want to die at home. They don't want to die at hospital, or they don't want to die at hospice. So they prefer to die at their home with their relatives and other people. So that kind of environment, so most of the time it's very important. So that is why this model, no, then especially that Indian model, then people say some, right, Kerala model. So where that actually that palliative care started in 1986. So in Calicut. So the place which is I have here, that put the picture that you can see that place. So where I got the training. So it is actually started like kind of a community clinics. The community clinics for the people with the chronic diseases. Then they expanded that. So you would have seen on this person, Dr. Suresh Kumar, that he was doing a few lectures for you, and also you were watching that video of Professor I got a thought block. Inila, what is our Professor Thiruvananthapuram?
Sorry, sir.
Our professor in Thiruvananthapuram, that is the father of palliative care India.
Dr. Rajagopal, M.R. Rajagopal.
Yeah, Dr. Rajagopal.
Yes.
Dr. Rajagopal and Suresh Kumar were there. No, then when we were starting, then Dr. Rajagopal was the professor. He was an anesthesiologist at the Calicut Medical School. So he was the person pioneered this palliative care thing. So when I was getting the training, I met an cardiothoracic surgeon, and he was sharing that experience because I met him in 2015, but this started in 86. But he was telling when they were young cardiothoracic surgeon, these anesthetic people were doing the pain clinic, not come to give the anesthesia in the theater. So then he was telling that we were really fed up. What these anesthetic people are doing, instead of coming to help and do the surgery, these people are running pain clinic. But after retirement, cardiothoracic surgeon is working at the palliative care center. Now that he realized that is important. So that's kind of a vision made them to develop this palliative care service by these 2 eminent people in India. So now then all of the people train Dr. Gayatri and team, and so now it has a kind of a, so this kind of thing, I can share you a thing. So they are the people change the model. So earlier palliative care, even the world thinking was to cater the terminally patients, but they change. So they change, it is post-traumatic paraplegia or fluctuating chronic disorders, sickle cell disease. filareal limb edema people. So in Sri Lanka now, we have almost eliminated the filaria, and then slowly progressive diseases, cerebral vascular disease. So all these things because of their vision, and then they started to treat all these patients. Then also WHO realized, so that is, yeah, that's really important to include. So, right now, initially they were using trained volunteers to make psychosocial support. So then main concept is, I hope that they discuss their main concept is neighborhood network. So then Dr. Suresh Kumar was telling then how to develop these volunteers. So these volunteers in the village are very important because we don't need to pay that much of money. So when we have a very low resource setting, but they are going to support their relatives, friends, and neighborhood person. So it's a kind of a, for them also, they have to feel and get the satisfaction while working there. So we should be able to make this kind of people and this kind of a community to work with us. Otherwise, we can't deliver the palliative care. We can't deliver the comprehensive palliative care, right? So the people working, no, then right, Dr. Jayaraj and here they're working in the mental health, you know. Right? So now even these last couple of weeks I am discussing with Dr. Sivajavan and another psychiatrist because that when they are starting MD in palliative care, so then they are very keen to understand. So what is happening then in the palliative care and how that could be incorporated, that actually the mental health aspect as well. So we need to have a community network. So community network able to provide support that all the aspects of palliative care, physical, mental, and social aspects of the care, right? Then they can support the families at home. Some of the networks are sharing the resources. The simple example, when we have a kind of bedridden patient at home setting, all the families can't buy beds. They can't afford to buy. So they need this one, air mattress or maybe the water mattress. So the air mattress is costing around 30 to 40,000 rupees. So water mattresses are cheaper. So then air mattress, so when they have 2 or 3 air mattresses in a community place, center place, so they can share whenever they need. They can share that with the family. So once the need is over, then they can get back that this air mattress can back to the center place, and then it can be shared with another place which is needed. So that's the way that community can share the resources. So I'm moving to this concerning the time factor. Already I mentioned that palliative care and policies and things are very recently launched. But in this is a hospice we have in here, but we have a hospice to patients to come and go for a kind of a temporary shelter. We get 1 or 2 patients for real palliative care and they come and stay and die. Some of the patients that there are no relatives to look after them at home, they come and stay in the here, and we try to provide all the care. But when they reach the terminal stage, end of life, then we don't have a 24 hours doctor's facilities. We have only one nursing officer, and then there are other healthcare assistants. So we don't have even 24 hours nursing coverage. So then we transfer them to the Tellipala hospital. So we have a kind of a shared kind of hospice care is provided. So when we want to provide 24 hours fully equipped and service providing hospice, we need a medical team, at least with the medical officer and thing. Later, we need to have a palliative care specialist to lead the team. So that should we need to achieve, right? So we are really doing some hospital and home-based palliative care with the support of Tour Cancer Collaboration, IMH Canada, particularly in Jaffna, and Jaffna particularly for cancer patients, Bonia that for the all the categories of patients based on the team is operating from Bonia Hospital. But we need to expand to other districts. That's why the training is going at the moment. So our next phase of training that we need to think about how we are going to develop these services in all these districts. So this is the model proposed by our strategic plan. Now that the Ministry of Health is working. So the patient with the limiting illness, they are maybe at the teaching tertiary and secondary care settings. So teaching hospital or district hospital, they may be a cancer, stage renal or heart failure, whatever the thing. So there must be at least one focal team and also leadership by the one really interested specialist. There may be a general physician or maybe oncologist or somebody who is really interested in palliative care, and it is good to have the person at kind of some sort of training to lead the team, and then be the medical officer and nursing. And also this strategy document is suggesting to have at least 1 or 2 beds in the ward. So in the general medical ward, they have to allocate 1 or 2 beds for the palliative care patients. And also there must be a place to run a weekly palliative care clinic. So then people can refer the patients to this palliative clinic. So there they can maintain the records. Then, so the palliative care in-ward service and then the consultative service, then they should be referred to the primary care. So the primary care doctors also need to be trained in palliative care. So they should know that how to manage palliation. And then there must be a nursing officer. The initial Ministry of Health started to train in 2018 100 nurses to work in the community setting. And then now again, next batch, they started thing, but because of this COVID, things are not moving, right? So, but they want to have, the idea is Ministry of Health to have a kind of a sorry for the interruption. So Ministry of Health want to have a kind of a community nurses. They must be available in the community. So then when these patients are at home, so these nurses should work with this volunteer group and with our public health midwives and the team. So to provide the palliative care in the community setting, and then they have to refer to this thing, primary care. Then we should be able to develop hospices. The hospices at the moment are not run by the government. It's like a NGO supported government shared hospices. So then we need the resources, medical officers and nurses. We need to get it from government, and also other care providing thing and running the meals and all these things are by the NGO. So this is the model that we will have to develop, and we need to discuss more with you each and every model, how we can set up. So at least we have to have one kind of a setting per district. So that is our aim at the moment. So if we can achieve that, then we could able to expand it more. So with that, I will also need to quickly say I was not able to do this availability of opioids in Sri Lanka. The Sri Lanka is a country we don't have enough opioid available. So now we have morphine is available in all 25 district teaching hospital, provincial district general hospitals. And drugs are mainly prescribed by the provincial these cancer hospitals. Right. So there is a policy for community-based hospice to morphine, but it's still we don't have kind of that available, because when we want to have a morphine, pethidine, or kind of opioid, we need to have a registered pharmacist available in the hospice or any institute. So that is another problem, that we don't have enough pharmacists to provide. So then we need more pharmacists to support this. And also most of the time it is available selling at the Osusala. Usually specialists and specialist people can prescribe morphine and these drugs for a month, and then the normal practitioners, primary care doctors can prescribe only for a week. So that is also another problem, that patient need to come every week when they are in the primary care. Otherwise they have to come to the central hospitals to get their 1 month morphine dose. So these are the preparations. These are the available preparations in the world, but only we have in Sri Lanka fast acting 10 to 30 milligram and slow acting 10, 30, 60. Earlier we had shrub, but now it's not available. And also, sorry. I couldn't. Right, and also we have injectables. So other formats are not available. And also we have a fentanyl patches, so 50 microgram and 100 microgram. And we don't have a methadone. So these are the things available. You can read more about these, about the pain management, control of pain. This is a pain management guide for adults with cancer. This is prepared by the National Cancer Control Program. So it's a good guide, and you can read. So this annex has right, how to use this morphine, and also this is a circular 2015 sent out by the Ministry of Health. It's actually for the cancer pain management. So we can use that for other people also. So this is a circular. Right. So this is the percent level of things that you can prescribe. Right. And then other one, this is a book I have written and to develop this palliative care as part of my academic thing. So it is highlighting that all what we have done in Northern Province and what we are thinking to develop with experts, well-wishers, philanthropists to develop the palliative care in Northern Sri Lanka. So this is some of these home care visits and they are seeing the patients. So this is some of the fundraising. You can see Dr. Varagunan and thing. This is the meeting that we had few months. This one, so you can
So we are
see
not able to
Jonathan.
see, we are not able to see your screen, sir.
Ah. Right. This is a meeting that we had in 2017 to discuss about the palliative care. So you can see some of the things, Gayatri, Jonathan, all that visited to our northern province and discuss how to develop. And then Dr. Kediswaran, Dr. Satyamurthy, all this. Okay. Now that question. Fine. Do you have any questions? No questions at all.
No question.
Do you have any question? Dr. Viduran? Sasika? Yeah, Viduran, you have any?
No, sir, no. No question.
You are Haren? Hola, okay. Okay. You know, you have idea because you are the people going to develop. So it's not only the training. No? So you have to support us to develop. So if you don't understand and how we are going to develop, so please ask. Then later we can also discuss. So discussion is very important, right? Don't take this as a kind of a
Sir,
class.
I have a question, sir.
Yeah.
Sir, that patients should have any records to have the morphine tablet with them? They should have any records with them?
Definitely.
Are we giving in the hospital that kind of records?
That is a problem. The good question. You can see, I don't know this book they didn't, but it's circular.
Legal issues.
Yeah. See, when you go to this circular, it prescribes the document also, the document that should be maintained, right? So this book, that part is not available, right? When you refer this thing, but again, this is a problem. Can't even. Most of the time, we worry about abuse, right? We are worried about abuse. We worry about the side effects of the morphine. So then, even most of our medical practitioners, even this very senior consultants, specialists, senior professors, and all. Still, now when we were studying in the medical school, also people say, this is very dangerous, So still, I can remember when I was giving my first dose of, was actually asking nurse to get ready with an naloxone, right? That's the way we study. So put that in there. But when you work with these patients, after working in India and things with these patients palliative, even some of the patients are in 1,000 milligram morphine daily dose, and they are just doing their day-to-day work, right? So they are not addicted, because when they have the pain, so then people have the pain, definitely they want. But that people will get addiction. So definitely there are issues. Even some of the, that's why this home team is very important. So home team, when they go, they have to check, right, whether they are taking or not. So otherwise, no point. No, then even from the clinic we can make the record, ask, and also when they are coming back, they have to really they have to bring back the pack. So whatever we prescribe, so they have to bring back, and then with the empty pack only we have to. That is practice they do in India. So patient has to bring the empty pack. That's the way they ensure. Then these patients are not they're at least taking. But even there also they found there are patients keeping more than 100 tablets at their home, morphine. So they can keep the tablet at home and they can bring the empty pack to the clinic. So if the patient start to abuse, that is very difficult to control. So that is global issue. But at the same time, we can't allow the patient to live with the pain. So most of our patients, yeah, because I am a public health person and community man. So why? Because I was doing my MD research in cancer patients. So I found most of the cancer patients were at home with all the severe pain and all the debilitating thing. Even this onco surgeon, that time Dr. Jayakumar was the onco surgeon in Jaffna. He was going to all the rural hospitals, running the clinics. Even he was doing clinic in Changane Heights in once a month. But even the relatives were not ready to take these patients to the clinics because they need transport or something facilities, but they are not having enough money. So the home care is very important. So that is unfortunately in Sri Lanka, even a few years back, it's so difficult for us to talk about with the Ministry of Health about the home care. But now they have realized. And also, unfortunately, our medical doctors and team people are not ready to go to the home. So our training also then, right? So now that we want, so even UK, the general practitioners are expected to go to home. Europe, they have to go. They won't go and see the patients at their home. But here that we have abolished that system. We had initially. So we need to have a home care team, hospital, then only then we can ensure this. I hope then I answered your question, Kandiban, or still? I couldn't hear you. I couldn't hear you. You are muted.
Yes. Sir, I am asking about the legal records to, but if
No, legal
tablets,
records.
morphine
Yeah,
at
legal records.
home, they should have a record. They should have at home also.
No,
Written
they should have.
records.
No.
No
Legal,
need.
they don't have to know it. They can't maintain. No. The legal document we have to keep it at the hospital. No, hospital should be under the lock and key. No.
The India that last practice, the last session, one of the session that one of the professor or some doctors told that they should have a record in India. If they having a morphine tablet with them, they should have a written record in India, legalized.
We don't have that kind of a legal. The record means that who is prescribed.
Yes,
How
that this patient is eligible to have this drug.
Yeah,
He can.
In Sri Lanka, we can't do this drug rehabilitation because anybody possessing like small amount of narcotics, then we can take any legal action. So anybody come and report, I am taking drugs, immediately we need a report. So we can't rehabilitation. So then people won't come and tell us. The drug abuse people, they won't come and tell us because then immediately we will report to the police. So Sri Lanka also we have that law. So then definitely they should show that it is prescribed by for the medical purpose by their personal records. And then they have to clarify. Actually, if they need, then they need to clarify. And also it's countable now. Even hospital, it is countable. Right? So it should be under the lock and key, and then maintained by the nursing in charge. Right? Then the pharmacist. So we had to have a registered pharmacist to maintain the stock. So all these things, laws are right. That is unique. Okay.
Yes. Any further questions?
Any question?
If there are any questions, you can always ask now, or you can put it in the chat. If not, like, we may have to wind up the session for today.
So, is there any discussion, I mean, future discussion about the how to start the palliative care in Sri Lanka, I mean, in Northern Province?
Definitely. That is the next phase of discussion. But we need to know that who are the people eligible. Attendance for this theory, and then we have to have a case discussion, and also then some of these because when we are discussing case, then you will understand, no, what sort of things and what are the issues and challenges that we face that to handle these cases. So then definitely we have to have a not this 1 hour thing that we need to, this is the introduction, no, it's a part of the theory thing, no. So but you will get receive these documents, so then you can also have a kind of understanding, but then that is the one of the part of the training. Right? You need to have a practical experience also, no?
So if there are no further questions, I think we'll just wind up the session for today. I think today is its last session in from our schedule for this didactic session. And I think we are going to all meet again on September 15th. And meanwhile, like, we have 1 week's time, we are going to look at the attendance of all the participants who have joined so far from the beginning till the last didactic section. And then, like, the committee is going to take a stand, like, who all will be included in the next part of the practical training. Based on that, it's mostly, I think, who have more than 80% of the attendance will be called for the practical and training and case-based discussions and topic presentations. That all that will be discussed during our next week's meeting on September 15th. And meanwhile, I request all the participants to kindly share your valuable feedback using the link in the chat box. Is that much? Yeah, I think Dr. Surya sir, should we say bye so that?
Bye.
we can
Okay, thank you
finish?
so much.
Yeah,
It's fine.
thank you everyone.
Thank you.
And see you all on
Okay, thank
September
you.
15th. Do not forget to share your feedback. Thank you once again.
Thank you.